Hello, my name is Alistair McNarry. I'm an anaesthetist in Edinburgh, and it's my privilege to welcome you to this edition of the Airway Management Podcast from Medtronic, the manufacturer of the McGrath Mac video laryngoscope. In this series of podcasts, we'll take a deep dive into the multifaceted world of video laryngoscopy. A technique I think that has changed our practice, or dare I say revolutionised our practice, everywhere that an airway might be managed, whether that's in hospital or outside it. In this series of 4 podcasts, we're going to be looking at the evidence for video laryngoscopy, the role of video laryngoscopy in paediatrics, teaching and training in video laryngoscopy, and look at the role of hyperangulated video laryngoscopy. Join us then as we uncover the versatility and impact of video laryngoscopy in the evolution of modern healthcare. In this episode, I am delighted to be joined by Doctor Alistair Baxter. He's a consultant paediatric anaesthetist in Edinburgh. And rather than me tell you about him, I'm going to let him tell you about himself, because I know he could fill an entire 20-minute podcast on cycling. However, his mission today is to tell you about paediatric airway management. Alistair, paediatric airway management and you, what's the relationship?
Yeah, well, thanks, Al. I started paediatric anaesthesia around about 2000 in Edinburgh Children's Hospital, and it's kind of always been this worry whenever anyone talks about children. The big thing they get worried and hung up about are how we manage their airways. There's always this idea that they've got slightly a different anatomy from adults. They've always got slightly different requirements with regard to ET tubes and laryngoscopes and all these things. So part of being a paediatric anaesthetist is always being interested in airway management. I was very conscious that during the early part of the millennium, we were getting thrown new devices all the time from airway management companies, video laryngoscopy devices to try. And I was conscious that in pediatrics, we cover from 0 years right up to 18 years. And as a consequence, we therefore have a vast selection of patients who require a vast variety of different devices to use. And I was very keen to see how the new devices that were coming on the market could be utilised in our patient group.
So I'm going to interrupt you briefly if I can, because I'm not a paediatric anaesthetist, but when I did my training in paediatric anaesthesia some years ago, I don't remember paediatric difficult airways. Are paediatric difficult airways a thing?
You probably do remember being very anxious when you came to paediatric anaesthesia, that everything that was worried about in paediatric anaesthesia was, oh, they've got these different airways, they've got these different laryngoscopes. You're happily intubating all your adult patients with Macintosh blade laryngoscopes, and suddenly you're coming into paediatric anaesthesia where you're having to start utilising straight blades and shoulder rolls and all sorts of unusual manoeuvres were being used in paediatric airways. When we actually look at the incidence that you would classically call difficult airways in children, the numbers are very small. And if you actually look at the first NAP program, they actually came up with very small numbers.
Now, I'm going to stop you again, because I realise this podcast goes international, and probably need to just mention what a NAP project is. I think most people in Europe know about the National Audit Project of the Royal College of Anaesthetists, but NAP4, the National Audit Project for the Royal College of Anaesthetists and Difficult Airway Society, specifically looked at major complications of airway management in all patients, adults and children, across the UK over the course of a year, I think between 2008 and 2009, published in 2011, and it's freely available to download on the Royal College of Anaesthetists website for those of you who need to read all 200 pages. But that's what a NAP project is. But I think NAP projects have moved on from 4 in 2011. They've moved on to NAP 7, which is about perioperative cardiac arrest. You don't get that, do you?
When you looked at NAP4 data, it kind of said that there was only 13 incidents of children were highlighted within that data, of which only 3 patients died. And it therefore seems that, well, maybe this isn't a problem in children. But if you actually now look at what NAP7 did, which was actually looking far closer at groups in what would cause cardiac arrest or ending up with CPR going on the table, airways were the most common cause of cardiac arrest in infants and children and neonates. If I look at the exact numbers, when you actually saw the data from the report, it says that laryngospasm was 52 patients ended up in cardiac arrest as a consequence of laryngospasm. Failed mask ventilation or misplacement of a supraglottic airway device was another 15. Hypotension was there, but then hypoxia ventilation difficulties, hypercapnia, hypocapnia were very much seen as causes of cardiac arrest in infants and children. So therefore, it was a far bigger problem than NAP4 had actually identified.
Okay, so my head's a little bit confused. When I did my pediatric training, I accept some years ago, it was all about using a straight blade in pediatrics. And yet when I look at the McGrath, there are size 1 and 2 blades that seem to be Macintosh shaped, not straight bladed. So I'm a little bit confused as to what's happening in pediatric airway management. How do you relate a Macintosh shaped video laryngoscope, granted a tiny one, to how you manage pediatric airways that I thought had to be done with a straight blade?
So as I said to you before, when you were doing your anaesthesia training, you came across the Children's Hospital and all these new things were thrown at you of big heads, large epiglottis, floppy epiglottis, very anterior, difficult tongue to control, and therefore you must use this specific blade that the consultant liked, and 90% of them were straight blades. The reason being that gave you control of the larynx, it gave you control of the tongue, and it allowed you a direct view of the vocal cords. The problem is you were the only person that could see that. The trainer had to guess that that's what you were seeing. 90% of the time you had no idea when you were training how to do this, and you were putting the tube somewhere where you thought was a larynx. You only found that out when you connected up to the circuit, the patient started to desat, because probably in the days you were training as well, you didn't have any end-tidal CO2, so you weren't probably checking that very closely. And actually what was happening is the patient was coming to calm. It was always the, if in doubt, take it out. Well, when we looked at the PD register data again from Philadelphia, John Faggio and his group showed very much that direct laryngoscopy is a failed technique. This sort of, I can get the tube in mentality meant that some patients were getting up to 20 attempts at direct laryngoscopy, which is crazy. It's this sort of task fixation, I can get the tube down, and without actually being able to move on, principally because the devices at that time, nobody really knew what other devices there were. What was the alternative to direct laryngoscopy? There was no alternative. And so during the early parts of the millennium, all these devices came out. You would try them, you would see what they were like. Did any of them fit for children? Did it also mean that you had to learn a new skill when you came into pediatrics? And I would kind of say, why don't we just work around the skills that you already had? As a trainee anaesthetist or as a consultant anaesthetist, you already had a vast muscle memory of having to use a laryngoscope, principally a Macintosh-shaped laryngoscope. So why teach you something new when actually when you look at the Macintosh-shaped blade, it actually is perfectly acceptable to find your way to the larynx, even in the smallest of children. I've used it in anything down to about 500 grams.
So I'm going to stop you there for a little second. Again, just phrases people may not be familiar with. Can we just go back and say, what's the PEDI registry? So
the PEDI registry it was run by the Philadelphia group in America. And what they did is they took all the episodes of difficult airway management that had happened. Voluntarily, these were reported back to this PEDI registry group. And they collated all the data and they looked at the data and they said, right, okay, are there any common themes that we can find from this data that could actually identify ways in which we could improve airway management? And they ended up with vast numbers. They were talking 40,000, 50,000 in the early parts, and now the episodes are much, much greater than that. And from that, they've been able to derive common themes that you would say, why are you doing this, or what we should be doing. It's all voluntary. It's not randomized control trials. It's a mixture of all sorts of data that they're getting. But it does give you a very good, clear indication as to what you should and shouldn't be doing in pediatrics.
I know that science and podcasts don't go together very well, so we'll come back to evidence in a little break. But I think you've managed to convince me that in your practice, and I think you've been using the McGrath Mac series for over 10 years, that you're using a size 1 and 2 Macintosh-shaped blade in all of your cases?
Yep. 99% of the intubations in my institution are done with a Macintosh-shaped blade, and McGrath Macintosh is the one that we use most common. The commonest reason that we wouldn't use it would be probably the mouth is too small, or we had to take time to teach straight-bladed laryngoscopy. So when we're utilizing the Macintosh blade, it's important to recognize that because, as you've said already, it's this straight blade. The straight line between the mouth and the larynx has always traditionally been used in pediatrics. It therefore means when you're using the Macintosh blade, which is slightly angulated. Now, in an adult, you'd say that's just a normal angulation on a blade, but in a child, it therefore would be regarded as slightly angulated. That slight angulation means that it's becoming a hyperangulated blade, as you would know in an adult practice.
So I'm going to get you to stop for just a second, because I think we're getting down to the nitty-gritty of actually how you teach pediatric video laryngoscopy. And that's easy for me because I ring you up and ask you. But actually for our listeners on the podcast, when do you say what size of child approximately are you saying use a size 1 blade? What size of child are you saying use a size 2 blade? What's your recommendation about stylettes? What's your recommendation about my favorite word, stylettiquette? So that's 4 different questions in one, which is really horrible. So I apologize for that, but take them in your own order.
I wouldn't expect anything less. As per all anaesthetists in the UK, we use whatever we're handed by our ODP, but we actually go out there and look to see what the evidence says. I would suggest that probably a size 1 blade is used less than 1 year old, and that's probably less than 8 kilos, 8 to 10 kilos. Again, it's difficult to say, because as with all things, when you're choosing a blade, you always have one a size above and a size below, you would say, but there is nothing below the size 1. So you're using it for a under 1 year old size 1 blade. The size 2 blade would probably go up to around about 4 or 5 years old, and then we can go back into the standard size 3 Macintosh blade from 5-year-old plus. Again, depending on the size of the patient.
And then stylettes and bougies and other such complex matters?
So as I say, because we've got a slight angulation on the blade, it's a bit like what you would regard as a hyperangulated technique. Now, I don't know how familiar people are with the hyperangulated technique. You're not actually seeing the larynx directly, you're seeing it round the corner. And so therefore, when you're putting a tube in, it's got to go round a degree or an angle to actually meet where your lens or your camera stick actually is showing. So what that means is when you're utilizing a Macintosh blade, it's a very slight angle, but it's still there. You need to therefore direct the tube towards the tip of the laryngoscope. And the best way to do that is with a stylette, to stiffen the tube and actually match it. If you match it to the curve of the laryngoscope blade, as you would do with other devices such as GlideScope, it therefore means that you get the tube being delivered to the front of your blade, as you would X-blades, GlideScopes, these sorts of hyperangulated.
Any tips and tricks? I know as an adult anaesthetist, there's quite a lot about making sure you use the stylette appropriately and you take the stylette out for a centimetre, things like that. Do you do that in paediatrics?
So yeah, again, you can't have the stylette pointing out the end of the ET tube. There have been episodes of tracheal perforation. You've got a relatively delicate trachea underneath, so you have to be aware of that. And again, then once your tube is built between the vocal cords, I would normally recommend removing the stylette before you advance the tube much further. Again, in paediatric airway management, it's not just about the video laryngoscopy, it's also about the insertion of the ET tube. You've got a trachea which can vary from 2 centimetres to 10 centimetres in length, so you therefore got to be very attentive as to how far in you're putting the tube. Another great advantage of the video laryngoscope is that you can actually see where you're putting it. The big problem, I suspect, in paediatric airway management is a mixture of the anatomy, the anatomical problems that I mentioned, the epiglottis, head, tongue, but it's also you've got a very fast uptake of oxygen, you've got a very low FRC. As a consequence of that, you've got limited time to intubate the patient, and therefore you add time pressure on top of anatomical problems, difficulties, changes in technique, and you're actually keying up an actual event in the intubation, which is actually quite challenging for most anaesthetists. They don't like the fact that the SATs drop very, very fast.
It sounds very much like you're describing an environment where the video laryngoscope is a tool to facilitate tracheal intubation, but tracheal intubation is a process. And I think probably sitting in the moderator's chair, I'm going to say clearly video laryngoscopy has advantages in pediatric anesthesia. You've outlined that. I'm going to ask you about the evidence in just a second. But it's clearly part of a technique that needs to be taught and learned. And it's not just something you can go to the cupboard and say, I'm going to intubate a child with a video laryngoscope.
So I would definitely say that the technique of airway management in children needs to be learned, and video laryngoscopy is part of that. So the actual laryngoscopy is a moment within a paediatric airway management event. So you've got to think about it beforehand. You've got to think and plan by having the right people, a good brief to tell what you're actually going to be doing. You've then got to make sure that the patient has got adequate anaesthesia. You've then got to think about, how am I going to provide oxygen during that down period of anaesthesia and intubation or airway management, and therefore blowing oxygen up the baby's nose has been proven again to be advantageous in prolonging that apneic period and taking that time pressure away. Then you're going to be looking at the intubation episode and making sure that that intubation episode is done with the best conditions. And there's, again, a growing amount of evidence that the first episode is the best episode for intubation. So if you can make the first episode your best, then you will get a far better success rate for the child in that airway management episode. There's often a reluctance in paediatrics, again, where we often use gas inductions to make sure we've got an adequate depth of anaesthesia. Then there's the functional episodes of where laryngospasm can occur. We don't have any IV access, and we then end up having to use muscle relaxants. So video laryngoscopy is just one component of that. But from my point of view as an anaesthetist and as a trainer of anaesthetists, it means I have security in knowing what's happened during that episode to make sure that the patient has got the best of airway management techniques. And I can see when an ET tube has gone down. I can see quickly whether there's going to be a more advanced technique required. And it's not a case of I've got to sit there asking again and again and again, Al, what can you see down the laryngoscope? What can you see down the laryngoscope? Tell me what you can see. I can see straight away what they're seeing. And so therefore I can make plans.
Now, unfortunately for you, and our listeners obviously will be paying close attention, they'll have noticed this too, you've referred to the growing body of evidence in paediatrics. So it's probably time to ask in 2 minutes, can you give us a kind of overview of the evidence for paediatric video laryngoscopy, or can you mention some guidelines that people can go and read? I know people read up on things after listening to these podcasts. Can you mention some guidelines they maybe ought to be going and reading by listening to this podcast again for us, every nugget?
Well, the first one I would go back to is, again, the Paedi Register data that came out in the Lancet, the Lancet in 2016, and that was where John Fadgeau and his group first produced the information about how many episodes of direct laryngoscopy and the idea of task fixation and not moving on. I think that's vital for anyone who wants to be looking at paediatric airway management to actually read the data that's out there. Other one that's come out has just been recently in the BJA, where they've actually looked at the European guidelines and for infants and neonates. And actually, again, they've highlighted the same sort of pathways as to make sure the patient is adequately anaesthetised, utilising video laryngoscopy. With regard to whether you should be using straight blades, curved blades, there is again a body of evidence which is suggesting that actually the easiest blades to use are the ones that you're most familiar with. So again, that comes back to muscle memory, being able to utilise the techniques that you've learned over your years, either as a paediatric intubator or as a paediatric anaesthetist, to use a straight blade if that's what you're used to using a curved blade in the Macintosh style if that's what you're used to, or if you're used to a hyperangulated blade, then utilising that hyperangulated blade in the best way you can. But again, the European guidelines have suggested that 2 attempts are what you should be doing. Once you get past 2 attempts at the technique you're using, move on.
Now European guidelines. So I'm a big fan of guidelines, as many of you will know. Pediatric guidelines, so that's really exciting. Can you tell us a bit about the role of video laryngoscopy in pediatric guidelines?
So recently, the British and the European Society for Neonatal Medicine has suggested that we should be utilising video laryngoscopy as a more prominent technique. They say that you should be utilising 2 attempts at direct laryngoscopy at most, and then moving on to video laryngoscopy. And in fact, actually, again, it's been highlighted that we should probably be utilising video laryngoscopy as our first choice technique. The Paediatric Airway guidelines, which have been for many, many years a source of discomfort for many paediatric anaesthetists in the same way as the DAS guideline. It just doesn't flow nicely, so that's presently under review. So we're actually in the review process for that guideline to actually look at the evidence again and move that one forward too.
And if I could push you for a prediction, what do you think they're going to say about video laryngoscopy?
If you could push me for an answer, Al, I think I would suggest that they will be very, very favourable of it in utilising video laryngoscopy as an early technique within the airway management tree.
I'm going to kind of hopefully let you off the hook shortly, but not without getting you to express some opinions. So number one, it's your opportunity to write the worldwide airway management guidelines in pediatrics. Should the first sentence say, always use the video laryngoscope?
I have to declare that I have got a vested interest in this because I am on the committee looking at this exact guideline. So I have to be careful. We need to look at the evidence is number one. But I do think video laryngoscopy should be our first go-to for all intubation events.
So, Alistair, we've talked a lot about the role of video laryngoscopy in pediatrics. We've talked about it guidelines. We've talked about the need. I'm not going to let you off the hook without talking a little bit about the role of video laryngoscopy in the bleeding tonsil, because everybody wants to know the answer to that. But before we get there, just tell me a bit about video laryngoscopy in your own hospital. Has it changed practice? What happens?
So as I said, we were early adopters, if you like, of video laryngoscopy, probably around about 2013. We started using video laryngoscopes in our theatre. Very quickly, it was seen as a great advance in our theatre environment. Our theatre manager, from saying no to most pieces of equipment coming in, very rapidly said yes. We've now...
I'm going to stop you because actually you're not saying the anaesthetist, you're saying the theatre team.
Yeah, the theatre team were the ones who chose this. This was not the anaesthetists. We brought in the device, let the anaesthetist use it. They quickly said, this is quite nice. But the theatre management and the theatre team very quickly said, this is a great advance. And actually now the whole hospital is equipped with video laryngoscope.
But I do want to pick up, you kept talking about we. Mm-hmm. You kept talking about everybody. Mm-hmm. That's not, you normally talk about the intubator, the person with the, but you seem to talk about the whole team. And that's, I know that's very trendy in anesthesia at the moment and airway management and airway safety, but you seem to be talking about it since the outset. So 10 or 11 years of human factors and better team working.
Yep, absolutely. Everybody can see what's happening. Everyone in the team knows what's happening. Your assistant can provide burp, moving the larynx around, the trachea around, helping you be able to quickly diagnose what's going on. And it then also gave you the reassurance that you weren't just the only person seeing what the troubles were or the difficulties you were coming into. Other people could see. So when you called for help, as you would often do, someone else could come in and very quickly see what was going on. And then you could decide, do I need an advanced technique? If I need an advanced technique, you've got that answer within a few minutes of starting your airway management event. And therefore meant that everybody was on board. It was very much the reason the device has been such a success in our hospital is because everyone was able to see the advantage that this device brought to airways in children.
Okay, well, I want to move on to the controversial questions now about our trainees and their exam preparation and what we're going to do about the bleeding tonsil. But I think also, whilst I'm a convert, because I know the advice you give me and I know what I would do in a child, not a pediatric anaesthetist, but if I had to intubate a child, I know what I'd reach for. I'd reach for a McGrath size 2-blade. But actually, remember, if you're a trainee listening to this podcast, please be guided by your trainers and by your local hospital safety policy. Don't just change your practice based on the podcast. Please go and look at the evidence. Please go and consider the evidence, and please make sensible decisions as a department rather than as an individual. However, you're not getting away quite so lightly. I'd like to talk to you about that exam chestnut, the bleeding tonsil. Trainees around the world prepare for anesthesia exams and various other exams, and one of those popular questions that gets asked of trainees in their examinations is, how do you manage a bleeding tonsil? And that frequently is in a child. As a pediatric video laryngoscope enthusiast, can you use a video laryngoscope in a bleeding tonsil? What about the risk of blood on the device or red out or all those problems? What's the perfect answer?
So the answer is to use the technique that you're most familiar with. And if that happens to be a video laryngoscope, then that's great. I personally think a video laryngoscope in my hands is exactly the device I would reach for the simple reason that it's what I'm most familiar with. I can see the larynx. My assistants can see the larynx. The consultant surgeon can see the larynx, all with the same device. And as such, I would quite happily suggest that a video laryngoscope is the one to use. Whether the readout, again, it's probably the worst question that you ever get because you can never predict what's going to happen. But from a readout is very, very rare with the Macintosh McGrath. It does not seem to be as much of a problem unless you dip the whole blade into a pool of blood, or it could be anything. It could be gastric contents. You can actually still see the larynx. The other advantage of it is if you can't see from the video, you can look and you'll find it down the direct laryngoscopy route, which is always a big advantage of a standard shaped blade, is if you can't see through the video for whatever reason, whether it be blood, whether it be debris, you can actually look down the side and do a direct laryngoscope.
Sounds like another study in its own right. Dr. Alistair Baxter, I think we have talked long enough. I'd like to thank you for the time and effort you put into today's podcast and for your contribution to this series. I'd like to thank our sponsors, Medtronic, for making this series possible. And I'd like to thank you, the listener. Thank you for listening. Thank you for watching. If you've enjoyed it, please tell your friends. Please comment below and join us on another one of our series of 4. We look forward to seeing you then as we explore how video laryngoscopy has improved and shaped patient care in the 21st century.
Thanks very much, Al.